if we want to like schedule it one after another, which one should be done earlier? The hymenoplasty or the vaginal tightening?
Same
Uh,
sitting.
Same sitting, I said. Why would you want to put the patient through anesthesia and everything? And hymenoplasty is altogether for a different reason, and vaginoplasty is altogether for a different reason. Suppose you do a hymenoplasty, you will want her to be there for 3 weeks, to be abstinence and all those things. And then uske baad, you are only, just doing all the things here.
Mm-hmm.
So what if the hymenal tag breaks? Or if at all vaginoplasty is done, why not reconstruct the hymen also? Many times, these days patients do demand, when they want to offer a vaginoplasty, a tighter vagina, they say that we would want our husband to experience the first time experience. So can you please recreate the hymen also? So we do that.
Okay, and again the same repetition. Ma'am has already answered it. I think so. We have done. Another question has popped up. Which procedure do you recommend for multiparous women who want vaginal tightening? EVDS or EBDS with hymenoplasty? That is
Uh,
EBDs with hymenoplasty.
but why would I, if a vaginoplasty, a multiparous woman usually wouldn't, and somebody who's delivered vaginally would not get very much affected with any energy based device. In those cases, we usually, whenever the patient is more than 2 finger loose, I never say energy based devices would do wonders for her. I do a surgical vaginoplasty for those patients. And in those cases, we can do hymenoplasty if they desire to do so. We tell them that we can even offer this to you. If they're wanting enough, then yes, we offer that to them. I don't do energy based devices for multiparous women, especially when they have delivered vaginally. It doesn't really help much. 3 finger loose, 3 finger tight, I think vaginal reconstruction surgically works better.
Okay. So we are done with the questions now, I guess.
I think we are done. We are done with everything.
Yeah.
Has Dr. Manvi joined? Yeah, thank you, sir. Thank you, Dr. Parul. My
Thank
small
you.
question.
Yes,
Do
sir.
you use the elixir of cosmetic gynecology PRP here also?
No, sir. But we tell them that we can, just to make it a little lucrative for the patients when they come for vaginoplasties and they're asking for hymenoplasties also. Then we just tell them there's something called as O shot and G shot. We might just club all this and it would improve your sex life even more. That you want a tighter vagina, you want a hymenoplasty. So we might even give a O shot or a G shot to her. So we do that. Many a times we just tell them that this is like, an added on service from our side. You will experience better orgasms and stuff like that. So we do that very routinely for these patients.
Okay. Thank you. Thank you so much.
Thank you so much, sir.
And yeah, Dr. Anjali is Dr. Thank you, Dr. Parul.
Thank
As
you, sir.
always, fantastic talk.
Thank you, sir.
Dr. Anjali is Dr.
Yes, sir.
Manvi here.
Yeah, I think I can see her.
See, the procedure can be repeated maximum 3 times. That is what Dr. Parul has done. I think in our lifetime, probably we will do one procedure. Unless and until you are too much into cosmetic gynecology, you may repeat it. But I think 1 to 2
I
times.
think I could also attempt the third time because I had my father-in-law who was a plastic surgeon and we could have, thought of doing it the third time. Otherwise, I think most of us wouldn't attempt it.
I can't find her here.
Yeah. Can is it feasible to call her because
Yes.
we have
Yes, sir.
current time? Yeah, yeah. In the meanwhile, since Dr. Parul and everyone is there, any questions from anybody? A small question, Dr. Parul. If the hymenal tags are not visible at all, then what do you do?
So posterior vaginal wall flap we take.
So in
That's when
that
we
case,
have to do a posterior vaginal wall flap hymenoplasty. We create a flap and we make a hymenal ring out of it. So
yeah.
that's when I say
So
that, if we have a plastic surgeon, it's always better because the blood supply should not be hampered. Otherwise, there would be tissue necrosis.
so that will be an annular, annular
Yes,
head, correct?
effectively. Yes.
Sir, I spoke to Dr. Manvi ma'am. She's joining in
She's
soon.
joining in. Yeah.
Yeah, yeah. Do we have a session on vaginoplasty?
Yes, sir. I think Manjula ma'am is taking it tomorrow. She called me today, and
Yeah.
I think we have it tomorrow from her. So, with your permission, can I just leave because 9 o'clock I've posted a section?
You're free to go. Absolutely no problem. Thank you. Thank you as always. Thank you so
Thank
much,
you.
Dr. Parul.
Thank you.
Hello.
Hello.
Hello. Are we having the next lecture?
I am waiting. You can see me waiting.
Yeah, but there was a big silence, so I thought.
No, I mean, I cannot continue to talk
नहीं 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 ठीक है okay fine.
till Madam joins. We will have silence.
Good evening, everybody.
Namaste, Dr. Manvi. Thank you for
Good
being
evening,
with
sir.
us.
I'm so sorry. Actually,
No?
in the morning, I was told that the time is 9 p.m. So,
Oh, so sorry. It's okay. No problem. I
so
hope you're.
yeah. So previously, I was told 8:45. Then in the morning, so there was a
Oh,
little bit.
ठीक है, कोई problem. कोई
I'm so
problem.
sorry.
If at
Yeah.
all you are ready, we can start with your
Yes,
talk.
yes. We'll
Thank
just.
you for being with us. Yeah. So, alert, Gauri, you are there?
Hello?
You are there?
Yeah, I'm there.
Yes. So, we are starting. Dr. Manvi is starting her talk. Dr. Manvi, you can share your
Thank
screen.
you.
Yes, sir. Is my screen visible?
Yes, ma'am. The screen is visible, but you can put it on full screen, or in case it's an
Yes,
issue,
yes,
you can
yes.
continue with the
I'll.
same. Yeah.
Okay. Yes. Is it visible now on full screen mode? I think it is moving also.
It's moving. It's full screen. You can
Yes.
start right away.
Yes, yes. So good evening, everybody. Today my topic is Mons Plasty. And before I start, I would just like to answer two queries which were there in the previous presentation. So one was on the tailor tack sutures, and one was the difference between the spindle, wedge-shaped, and football-shaped resection in labia majoroplasty. So for the first query, like the spindle shaped, wedge shaped, and football shaped, so they are nothing but the shape of the markings which are done on the labia majora tissue. So that is in accordance with like which kind of resection the patient is suitable for. So obviously, when you are marking a spindle, so it is obvious like the labia majora is not in a great bulk, versus when you are marking like a football shaped incision, and as I told that the medial edge of the incision is usually in the interlabial fold to just to conceal the scar mark later on. So mostly the outer shape is what usually varies, and they have just given names just to elaborate, like it looks like a spindle, or it looks like a football, or it looks like a wedge. So that is the difference. And about the second query, which was the tailor tacking. So tailor tacking is basically, it's in the name only. So it is tailor tack. So it is a technique which is used basically by tailors. So what is there, like suppose they have to sew certain, buttons or anything. So previously what used to be done, like if you mark it with the chalk or anything, so it produces a mark later on in the fabric. So what they do is like they put stitches over there. So they are basically to ensure that the marking or the placement of the buttons is at the right place. So similarly, in surgery or in these surgeries, the concept of tailor tacking is to reduce the asymmetry. So if you just tailor tack or take some of the sutures. Suppose last time we were talking about labia majora plasty. So in some of the in the suture line, you just mark those tailor tags, like just place a few sutures for your reference, that where you would be putting the next of the sutures. So obviously when you would be suturing, so your incision or your scar is more likely to get symmetrical. So I just wanted to clarify this before we start the next topic. Okay, so today our topic is mons pubis. And as you all know, that mons pubis is a rounded eminence which is made by fatty tissue lying in front of the pubic symphysis. So this area is the mons pubis. So obviously a few fine hair may be present in the childhood, and later at puberty they become coarse and more numerous. And upper limit of the hairy region is horizontal across the lower abdomen. So as we call it as the female eustachian. So that all we have read. So it is located anterior to the pubic symphysis and superior to the labia majora. So all of you are gynecologists, so I don't need to get into the details. But obviously, we should know the boundaries just for completion purpose. So superiorly, the boundary is the lateral junction, okay, with the boundaries are the lateral junction with the thigh, okay, then superior boundary with the abdomen at the end of the hair bearing line, and inferior margin where the mons transitions into the labia majora, creating a vaginal cleft. So here, so these are the markings of the uh, labia majora. So mons pubis plays a critical role in genital contour, in maintaining the genital contour. Yes, every organ here is erogenic, as is true for the mons pubis as well. So it is an erogenic area because it provides a cushion during sexual activity. So obviously it plays a role in sexual confidence and also in the garment fitting and comfort. So a lot of females who wear tight clothing, they are actually concerned with the amount of fat tissue present in the mons pubis. So often overlooked, it yet contributes significantly to vulvar harmony. Okay, so the what are the structures which are present inside the mons pubis? Just in giving you an overview. So we have an adipose pad of fat, which determines the bulk and the projection of the tissue. Then we have the skin, which is subject to wrinkling, hyperpigmentation, and laxity. And the fascia, which is overlying the pubic bone and provides structural support. And the hair bearing area, as already discussed. Now what is important over here is like different from the other organs is it is a superficial adipose layer and the deep adipose layer. So what is there is like in this superficial adipose layer, all the fat compartment is very compactly arranged, and in this deep adipose layer, so it is not so compact and is contained within a loose, less organized, and more widely spaced facial septa. Okay, and then subcutaneous fascia above and muscle fascia below. They form what is termed as the deep adipose compartment. So it cannot be considered as just fat. So that is what is the point of just stressing this out, that it has got subcutaneous fascia above and muscle fascia below. Okay, so all this has got importance when you are doing surgery. So one more thing is there, like the deep adipose layer contains the lymphatic vessels, which are concentrated in the lamellar layer of subcutaneous fat, and they drain into the which nodes are there? There are inguinal nodes over here. Okay. And a thick lamellar layer means that a great number of perforating vessels are also present. So perforating vessels, I mean by that arteries, veins, as well as lymphatics. Okay. And excising only the areolar layer of the pubic area preserves these vessels, avoiding actual complications. So all this is important for when we are talking about the surgical complications related to this procedure. Okay. So this we have already discussed. Yes. So I just wanted to tell you about the innervation and the vascular supply of this region. So mainly the nerve supply is by the ilioinguinal nerve and the genitofemoral nerve, and the vascular supply is by the external pudendal vessels. So obviously it has got an important consideration during liposuction or monsplasty. Okay. Yeah. So this is just a pictorial representation. So this is the ilioinguinal nerve and the arteries which are present over all these areas. So they are the main artery is coming from down. It is the femoral artery, and it gives various branches like superficial external pudendal artery. Then you have the deep circumflex iliac artery, and then the superficial epigastric artery. So all this anatomy you should know. So now we come to like what is the need of this surgery? Okay, so obviously there are both functional as well as emotional concerns which are associated. So patient feels that there is an excessive bulge which is visible through tight clothing. She has discomfort during physical activity or intimacy. She has aesthetic dissatisfaction, mostly post pregnancy or weight changes, and it has got a tremendous impact on self image and sexual well being. So, what are the factors like in a female's aging cycle or reproductive cycle, a lot of changes comes wherein there is a loss of all these genital organs. They change in anatomy and function. So with aging, there is a loss of skin tone and increased ptosis. So the term ptosis means basically drooping. Okay, so used in mostly in the eye. So we say the ptosis of the eye. So weight gain or weight loss alters adipose deposition. Especially after bariatric surgery, what happens is there is a tremendous amount of artificial weight loss which is happening. So when you take care of one compartment and you are not careful in taking care of the other compartment, by which I mean the abdomen and the mons pubis, so obviously this deformity can result. Okay, then in postpartum period, there is a lot of skin laxity and altered fat distribution. And of course, when we are giving our conventional C-section scars these days, the Phanon-Steel scars, so they may lead to contour irregularities in the mons pubis. Yeah, so before I go further, so what are the effects what all this is causing to the patient? So psychosocial discomfort and embarrassment is a huge thing uh, by which the patients will approach to you for surgery. And in some cases, deformity can be visible even under the tight clothing. Okay. So now we come to the key clinical steps of evaluation. So physical examination, you have to see the degree of bulge, then the skin laxity or ptosis, the texture and the pigmentation of this area. So all this, wherever you are doing, the whether on the labia minora, the labia majora. So all this is very important before ultimately, because ultimately we are going to suture two different layers, and you are excising a bit of it in most of the procedures. So the skin, to match the skin is very important. So that is why pigmentation, and you have to assess the patient for cicatricial tissue post surgery, then associated labial or abdominal deformities. It is very important to plan the surgery properly. Take help of your plastic surgery friends, whatever, and obviously symmetry and adjacent tissue quality. Yeah, so understand the patient's expectations and motivation and rule out underlying conditions like lipedema and hernias, and document photographs and consent. Yes, medical legal consent is very important. Discuss potential need for staged procedure. So it may not be possible to address all the deformities in one go, and staged procedure may be very essential. Okay, so previously, everything appeared to me as same. So all this, I thought when I was not aware that, okay, these are different pictures of mons pubis, but slowly and steadily I understood that, okay, we are talking about different things here. So just coming over here. So there are mainly two classification systems which are focused on classifying the degree of Mons deformities. Obviously, when you need to correct something, you need to grade it. Everything you cannot say in cosmetic gynecology, okay, it is subjective. Patient is getting discomfort and whatever. So, so this is how you grade. So number one is your mild bulging with minimal or no show of the external genitalia, coverage of the external genitalia. So this is uh, grade 1 deformity. Okay, then grade 2 में क्या होता है that there is a moderate bulging with a partial covering of the external genitalia. Then this is grade 3, that it is a marked bulging with almost complete covering of the external genitalia. And you have grade 4 when there is no bulging with partial or complete covering of the external genitalia. So why this uh, staging or grading is important? Because you want to plan your procedure. Okay, so mostly in grade 1, plain simple liposuction would serve the purpose, but in like grade 2, you have to do a liposuction assisted paniculectomy. Then in grade 3, you have to go further, like you have to do a uh, liposuction assisted paniculectomy plus a vertical dermal suspension sutures. And in grade 4, you have to go for all this, like the vertical wedge excision also sometimes. in apart from whatever is done in grade 3 to address the horizontal laxity, because as you can appreciate that there is some degree of horizontal laxity also which is there. Okay, so just an overview of the treatment modalities, like what all is there. So now the choice, how do you decide like what treatment or what treatment modality you are going to use? I just demonstrated like there is a classification system by which you can actually grade the deformities of the mons. Apart from that, you have to see subjectively all this, like the volume of the fat, how much is amount of fat, then what is the skin quality, then what is the degree of ptosis, and then the patient preference for surgical versus like some patients do not want to undergo surgery. So definitely we have options, non-surgical also, but they would not work in all the cases and the patient should be properly informed about it. So treatment options obviously may be standalone or they could be combined. So talking about now the non-surgical options. Okay, so they are ideal for mild cases with good skin tone. There are a lot of equipment which is available these days. Lot of energy-based devices are there. So one, just to enumerate, cryolipolysis is something which is called as cool sculpting. It targets the fat cells by controlled cooling, causes controlled cooling. Okay, so radio frequency or high intensity focused ultrasound or even this procedure. So it stimulates the collagen tightening, and the disadvantage of the non-invasive procedure that a single session may not be sufficient. Patient has to come repeatedly for different sessions. Now, injectable therapies, obviously, I'm not talking here about totic mons or mons in which patient is complaining of excessive bulging of skin outside her clothing which is visible. So I'm talking about where you want to enhance the skin turgor and contour. So there, these injectable therapies may work, may produce some effect. Like you have the hyaluronic acid based dermal fillers, which improve the volume in the mons or adjacent labia majora, and then also TRP or biostimulators, which improve the skin texture, hydration, and tightness, and they support tissue healing and rejuvenation. But as said, like a very minor fraction of the patients would benefit from this, because a patient who would approach to you for monthplasty definitely has a lot of deformity with which she is embarrassed. So the mild cases are rare, and so we have different techniques. So first of all, just liposuction, suited for which kind of patients? So those who have a prominent and fatty mons and they have a good skin elasticity, and it can be combined with labia majora contouring or a tummy-tuck cesarean section scar revision. So I'll come later on to like the combination surgeries and all. So I think all of you are aware or not aware, so I just enumerated the major points. So liposuction or the surgical technique, basically it is done under local or general anesthesia. You the word is now tumescent infiltration. So there is a lot of infiltration solutions which are available when you are doing liposuction. So common solutions are, the clean solution is very common. So use of micro cannulas for precision. So there are a lot of diameters of micro cannulas which are there. Depending upon the need, the different numbers can be used. And the principle followed everywhere: avoid overcorrection to retain the natural convexity of the mons, and post-op compression garment is advised for 2 to 4 weeks. Now, just a basic about like what is mons plasty. So the other name which is used for this procedure is a pubic lift procedure. So it is a skin excision with or without fat removal, and often performed when there is ptosis or sagging is significant and there is redundant skin. And scar placement is usually we try to conceal in the natural crease and usually combined with an abdominoplasty procedure. So that is the basic with what is there. So whenever a Mons plastic procedure is being performed, you have to do a meticulous perioperative marking. So it is crucial for symmetry and scar placement. So basically, our final scar is going to lie somewhere here. Okay, and there is obviously undermining and re-dripping of skin, and it cannot be can be. It has to be a layered closure to prevent the dead space. I'll just show you some figures later on. So okay, so this is just a figure to show the extent of excision which is carried out. So obviously there is a lot of space which is there. So you have to do a layered closure over here, and I'll just tell the major points, like what points to keep in mind while you are suturing. So a layered closure is essential. So yes, before I go over here, so I just uh, tell you about the major steps which are followed. So after the patient is usually given GA for this procedure. So usually, where is our incision line? So incision line is marked, which is about 7 to 8 centimeters above the commissure of vulva, and it is extended laterally as needed for routine abdominoplasty procedure. So I was telling you that we infuse something. So these markings are there from where you insert the liposuction cannulas and you infiltrate. So what infiltration is done? So usually it's 0.1% lidocaine and in an epinephrine or saline 1 in 1 lakh concentration to create a tummy sense of about 2:1. And if the procedure is combined with a liposuction, so obviously, so liposuction can be performed after this tumescent infiltration is achieved, because usually it is a combination liposuction, Mons plasty done in like combination techniques. So uh, now I'll take you to this figure. So now what I was talking about, like, okay, you gave the incision, okay, then you went layer by layer, and then you excised the requisite amount of like, the what. So this is the whole marking. So then after you have removed the requisite amount of flap, whatever was needed to be removed. So now it is very important to do the dermal facial suspension. So what is the concept of dermal facial suspension? So it is usually used in grade 3 and grade 4 deformities. So what I just showed earlier in the during the initial part. So basically what we have to do is that we have to anchor the facial dermal suspension to rectus sheath. Okay, so there are different fascia which are present over here, and the superior tension which is created by this dermal facial suspension of Mons, you should understand, like when you are placing this uh, suspension sutures, so it has to be in such a manner that the direction of all this stream of urine, okay, does not alter the location of clitoris or the meatus of the urethra, because you have to keep in mind that ultimately you have to create like sutures which have to be again in the entire result should be in the anatomical position. So while suturing such a big incision, so obviously these points, if they are not borne in mind, so you can cause deviation in the stream of urine later on. Okay, so in that case, the clitoris will become more exposed over here, and in the when you are achieving a normal anatomically coherent result, so clitoris will become, obviously when this will get pulled up, okay, so clitoris will become more exposed, allowing for improved sexual stimulation, and it provides a long lasting lifting with no contour deformity. Therefore, in most of the cases, the surgical procedure is considered superior to the liposuction procedure. Okay, so now I'll just explain this figure. So what is this? This is what I was talking about, the dermal facial suspension sutures. Okay, so used in, so these blue ones are the dermal facial suspension sutures which are there. So they are used for anchoring the fascia to the rectus sheath. Okay, so penetrates the facial system and dermis, and it is then fixed in the rectus sheath. Okay, so the aim is to produce, you have to produce an equal skin, you have to produce an equal rectus muscle, and you have to produce an equal symphysis pubis. So everything should be in cohesion. Okay, so also I think this is just, I would like to mention in this particular diagram only that there are few landmarks which we are using. Okay, the bony landmarks. You can see all these markings. Okay, so there are the basic landmarks are the first landmark which is placed 2 to 3 centimeter below the pectineal line of the pubic symphysis, whereas the median suture is placed during surgery here. Okay, and the lateral two landmarks. So they are placed 2 to 3 centimeter below the pectineal line of the pubic tubercle, where the lateral sutures are placed during surgery. So all this has to be kept in mind. So then, yes, so this figure is also important to see how much wound you are creating. And it is very important. So while you are starting your suturing, so the undermost or the lowermost layer when you are suspecting the fascia, so skin and subcutaneous tissue of lower mons is pulled upward and tacked to the rectus sheath with 2-0. You can use PDS over here. So that is a very strong suture which will give the tissue strength. Okay, and as you keep on approximating, okay, so then you can use in various layers, you use different sutures, but over here you need to use a suture like you can use nylon or PDS sutures. So once you are coming up, so it is very important. So here also we use tailor tacking techniques. So as you can see that the incision is so big. So I'll just demonstrate over here because it is better with the picture. So when you are doing the tailor tacking means now I am suturing and I have come up towards the skin. So I place like my tailor tacks somewhere in between. So I can use a skin stapler also to do the tailor tacks throughout the entire line to just approximate this. So I can like when you close a skin of a cesarean section. So you place a suture in the midline so that your midline is secured and now you can just suture on the left side and the right side. So similarly over here, because this is different because number one, there is a much extensive amount of excision which has been done. And number two, it is a very, very big incision. So it usually takes a lot of amount of time and lot of sutures and lot of layers so that there is proper strength and there is a least amount of wound dehiscence which occurs later. Okay, so now a word about the vertical monsplasty techniques. Okay, so now we have just now seen the horizontal technique, okay, which is the conventional monsplasty or the pubic lift procedure. So there is something which is called as a vertical monsplasty technique also. So in that, obviously you do all your basics, whatever you do in the regular case, like patient, you first evaluate in all the positions, including the standing position, which is very important. If you would have noticed the preoperative figures, they were all in the standing position because there you assess like what is the amount of ptosis and what is the amount of deformity the patient is facing. Okay, then you note about the width of the mons, amount of the ptosis and the tissue laxity, and the midline of the mons is marked on the lower abdomen. And when the patient is supine, amount of fat and skin that can be excised without lateral tension is tested. Okay, now we come to like what is different in this vertical monsplasty technique. So there is a V wedge. So as you can see, this is a wedge. Okay, for excision is marked from the pubis or the mons junction. Okay, to the vaginal cleft. So over here, and it can be an ellipse also. Ellipse means like this. Okay, and or if there is a pre-existing scar from a cesarean delivery or abdominoplasty has been done before, so there can be lateral extensions at the abdomen also. So tissue is excised through skin and ample subcutaneous fat is limited to the deep investing fascia. So this is how this technique is carried out. So yeah, so what you have to keep in mind in this particular technique is that the neuromuscular bundles from the pudendal nerve, they approach laterally to the clitoris and they are protected by their depth and inferior and lateral position. So that you have to just take care like where to incise. Okay, closure is again multi-layer. So the principle is the same. Like you have to use like the imbrication of the deep investing fascia with 20 PDS and deep dermal and subcuticular. You have to use like 40, suture like 40 monocryl. And obviously the skin tape is very important when you are just closing your incision, and after incision to just apply on the wound. Okay. So then, so what is the advantage of this technique over the conventional technique? Basically, there is less formation of dog ears. So dog ears, because they are placed upwards and downwards. Okay, and this dog ear can be hidden in this crease. So that is the main advantage. Sorry. Yeah. So, of course, combining techniques for optimal results is very, very important. So, no single method is usually sufficient. You have to individualize your case. Sometimes you have to combine a liposuction with a Mons plasty. Sometimes you have to combine a Mons plasty with a labiaplasty, or Mons correction with a scar revision. So, a tailored composite planning enhances the outcomes. So, we will come to the complications, but what key considerations you have to take or in note for the patient selection? Like, not every patient or no, not every case needs surgery. So sometimes it could be manageable with your. I would not say like the energy-based devices. I do not have much experience of EBDs in this area, but yes, a simple liposuction can serve the purpose, but the ideal candidates for the procedure would be like who are concerned about the Mons contour or visibility, and they are physically healthy and they have a stable BMI. Non-smokers are willing to stop smoking, true for every cosmetic gynecological procedure. Then realistic expectations about scars and downtime. Yes, the scar is very big in this procedure. It is not like a scar which is not visible also like the other surgeries like labia minoroplasty or majoroplasty. They are concealed in the genital area, but here the patient can see the scar. So that is important. So therefore, you should clearly communicate about the procedure goals and limitations to the patient prior to your planning the surgery. Then about the recovery timeline and the potential need for adjunctive procedures. Okay, and you have to emphasize like even if you do your best surgery, even if you do your best procedure, there is a variability in the outcomes and individualized care plans have to be formed. And you have to address, like we last time discussed, address the psychosexual implications whenever relevant. You have to assess the patient, rule out any psychiatric disorder, rule out any body dysmorphic disorder before you take up the patient for surgery. So I think I have discussed all this. And yes. So now what are the general guidelines? So you have to encourage the use of compression garments for at least 2 to 4 weeks. A lot of edema is common after this procedure. Why? You are doing an extensive excision. So a lot of lymphatics, a lot of perforating vessels, they are getting disrupted, and obviously there has to be like a lot of tissue edema. So a compression garment is of great help in curtailing the progress of that. And then, of course, antibiotic and analgesic prescriptions. Then avoid vigorous physical activity and sexual activity for 2 to 4 weeks. Even the patients who look at their scar quite commonly or quite often, so they have it is seen that they have a greater incidence of wound dehiscence. So because that has a scientific rationale behind it, that produces strain on the scar, stress on the scar. And this you have to tell to the every patient you do any cosmetic gynecological procedure. And of course, you have to monitor for. So these are the complications. There can be a seroma formation because of all this we have mentioned already, and there could be infection, and of course, scar issues. There's a big scar. The way you can just prevent the scar formation is by an elaborate, extensive, layered suturing protocol, because uh, it is you need like because the excision is so extensive, you need support at multiple levels for tissue strength. So that is the rationale behind when you are doing a layered approach. So now how to manage the complications. So Obviously, if you are facing issues like minor asymmetries, so they often resolve over time, or they can be corrected later. If there is a seroma formation, if it is very big, it may require aspiration. Uh, it may not be always, I would say, the surgeon's fault that the patient is presenting with a hypertrophic scar or a keloid scar. Patients have genetic tendencies, especially Indian skins are uh, dark when we compare it to the Western skin. So there is a more tendency for keloid formation, hypertrophic scars. So yes, silicone gels have some role, not much personal experience with that. Steroid injections, yes, steroid injections are very useful. And numbness, because I told you, like, the nerve supply over here is by genitofemoral nerve, the ilioinguinal nerves. Obviously, all those are getting like you are hampering all the blood vessels and the nerves. So usually transient, and you have to educate the patient preoperatively that they are going to face this issue in the post-operative period. So now outcomes and satisfaction. So everything depends upon your counseling, like how you counsel the patient before the surgery. So patient has a high satisfaction when patient expectations align with the outcomes and proper technique and holistic planning are employed. This procedure obviously enhances the confidence in the intimate settings. It is not something which the patient can just flaunt outside. She can flaunt if she is wearing tight clothing, but the confidence on a day-to-day basis definitely improved after the procedure, and body image post childbirth or excessive weight loss, as mentioned, like bariatric surgeries. And of course, very, very important that you have to document before and after photos for patient records. So, yeah, so these were some case studies. So, what kind of patients would usually come for this kind of procedure? So, like a patient who is post childbirth comes to you with a bulge in the mons pubis. So, just what is done with the local anesthesia, you can do just a tumescent liposuction, and it would result in improved contour and no visible scars. And like when you combine a monsplasty and abdominoplasty, the patient would come somewhere with a history of, post pre-pregnancy, she has a mons pubis bulge, sagging lower abdomen. So combined procedure like abdominoplasty plus monsplasty has to be carried out. And sometimes, just there is a mild mons fullness, but no ptosis is there. So cryolipolysis plus RF tightening. But obviously, uh, multiple sessions are employed. Even 2 sessions may not be enough. So just coming to the takeaways from this presentation, the mons pubis plays a pivotal role in genital aesthetics. Treatment must be personalized and multimodal. Non-invasive methods are useful for select cases, and surgical correction offers long-lasting results with proper technique. And it is important to approach with clinical and aesthetic balance. So thank you so much. So I can take any questions if there are. Hello. Can I just see the chat box? Okay.
Yeah, I believe there are no questions in the chat box.
Okay.
Yeah, there aren't any questions, ma'am, right now in the chat box.
Okay.
You have elaborated it so very well, I guess. Maybe that's why. Yeah, somebody is asking for videos of the procedures.
Okay. So personally, I've done like till now 2 procedures, like two. So personal videos are not there, but yes, in the times to come, I would share.
And could you please repeat the tumescent concentration?
Okay. So what I mentioned was like 0.1% lidocaine with 1 lakh of adrenaline or epinephrine. Then, ma'am, what's Okay, so what skin sutures are used for vertical and horizontal plasty? So when you are doing the skin suturing, basically the skin is the most important part because the healing is what is visible to the patient afterwards. So when you are suturing skin, uh, okay, so basically when you do the normal or subcuticular suturing with monocryl, you can use 3040 monocryl. And after that subcuticular suturing, still sometimes you have to, because it is a big scar, so sometimes you have to apply wherever there you find a contour irregularity. You can place like Vicryl or any suture, any removable suture also, which you can remove later. Obviously, entire depth there would be absorbable sutures, and outside, if you have a meticulous, if you apply those tailor tacks like staples or whatever. So what happens is like your big suture, it gets divided into small parts. So it is easier to suture in parts and bits. So then you can remove those staples later on, and even just suturing with the monocryl can give excellent results.
Ma'am, can threads be used for Mons lift is another question.
Okay, so people are using threads, and I think there are better persons than me who would elaborate for the thread lift. Personally, I do not prefer threads, but yes, they would be useful in mild cases.
Okay, ma'am. And there has been a request for vascular and neuroanatomy pictures of the Mons. If you could please share them with us, ma'am.
Okay. Yeah, so I just showed one picture with the vessels and all, so I'll share that.
Ma'am, one more question. I want to ask which procedure is better, cryolipolysis or HIFU per se? Apart
Okay,
from
so
liposuction for that Mons reduction and liposuction
okay,
in
so
total.
cryolipolysis is something which is new. I haven't done personally cryolipolysis. But yes, liposuction and monsplasty are the gold standard which have been used, and we need more experience with that, the newer techniques. And liposuction would be ideal for the mild cases, and monsplasty or the pubic lift for the where there is a big amount of forces.
And what about the radio frequency thing?
Okay, so they are all, madam, they are all non-invasive things. They are all the
Yeah,
energy
that's
basic
what precisely I'm asking. Which one is better, cryolipolysis or radio frequency or HIFU in non-invasive things?
Okay, madam, उसके लिए ट्रायल करना पड़ेगा.
Okay, thank you.
Yeah, because see what happens is whosoever has a particular technology promotes that particular technology, and we don't have much scientific backing कि उसका comparison उसके साथ करेंगे तो क्या होगा, unless there is unbiased clinical trial. हाइफो जो यूज करता है इसे मुझे उससे रिजल्ट आ रहा है, आरएफ जो करता है बोलता है इट इज के रिजल्ट्स एक्सीलेंट है. So I think each and every technology, if properly utilized and for the proper patient, for the proper indication, would give result.
Okay.
Okay. Ma'am, do you recommend the minivac drain for the subcute?
I think that it is a prophylactic measure to prevent seroma formation later. So yes, like it could be a prophylactic measure in select cases.
Okay, great. So we can use that minivac drain. And steroid prophylactically or early suture removal, which would help in preventing the scar keloid and everything, ma'am.
Okay, so yes, the use of steroid, like to prevent like prophylactic. See, in the, I in many countries they are using steroids to prevent the scar formation, but it is not a practice like which is followed all over. So yes, it dexamethasone they give for like 5 days, prednisolone they give. So because the basic mechanism of everything is inflammation wherever you are getting all these abnormalities. So once you are curtailing that inflammation process, so obviously the results are going to be better. But ultimately we have to rely on the patient's own immune system.
Right, ma'am. I think we are done with the questions in the chat box, ma'am.
Okay.
Yeah, I
Kiran
think
sir?
we're done. Yeah, I think we are done. Any other questions? If there are any questions, you can unmute yourself and just ask. How long to keep drain in abdominoplasty? Till
Okay,
it drains.
yeah, so it would vary. I think if there is going to be a seroma formation, it would not extend beyond the very late. It would be in the early post-operative period, maybe 24 to 48 hours is the basic period where you get any OMA formation, whether it is seroma, hematoma, whatever. So yes, you can remove it after 3 days. Okay, what is the long-term satisfaction after isolated Mons plastic? Yes, so I think there is not any percentage which I have to quote over here. But yes, if Monsplasty is done for the correct indication, I have stressed it throughout my presentation that it is a good procedure to improve the patient's body image. So yes, a patient who comes like for an isolated Monsplasty, if she's indicated, if she doesn't have any indication for the abdominoplasty or something. So yes, good results. So when to remove sutures? So please take note that mostly we have used absorbable sutures, okay, and we don't need to remove that except when in the most superficial layer you may take some sutures according to case, not recommended, but just if you notice some contour irregularities or anything. So then you can remove it like by after 7th postoperative day. What modification needs to be done in previous LSCS? See, actually, the thing is in a previous section, what difference is there? You have fibrosis in the tissue. So once you have excised all the tissue, it is not like a previous cesarean section, cesarean you are doing. You are doing entire pubic lift where you're excising a lot of um fat tissue of the mons pubis as well as the abdomen. So obviously, what you are approximating is nape tissue. So it's not going to make much a difference. Okay, so as vertical monsplasty has smaller incision area over the horizontal one, are there fewer advantages of it over the horizontal one? See, the horizontal one is the uh, major and the standard technique which is used. Okay, so the vertical one would be used in particular indications. It may not be suitable for all the cases, as you can just see by common sense that it would not be able to address the laxity or the excessive amount of tissue in the abdomen. So it would just address the mons. So not suitable for all the cases, I would say. Proper patient selection is important. It would reduce the mons in the lateral dimension. And it would, as I mentioned, like the advantages that it would help reduce your dog ears formation, like at the end of the scar you get. Do you advise subcute stitch? Yes, I do. I'm a big fan of subcuticular sutures. I think they impart a cosmetic appearance and good healing outcome. Yeah, so someone has written that she did a patient who had a one section long back and then abdominoplasty, no difference in technique of LSAS. Only patient had a lot of pain and hyperalgia post abdominoplasty and post LSAS. All these symptoms had gone. Yeah, so I think that is repetition. Yes, so patient, you have to uh, obtain adequate pain control in the post-operative period because it is a big excision. Yes, thank you for that experience.
I think, are we done? I don't know.
There are no more questions in the chat box as of now, sir.
Okay. So then we call it a day. Thank you, Dr. Manvi.
Thank you, sir.
Thank you again for being with us. Thank you for giving your time. Thank you so much.
Thank you, ma'am. Thank you, sir.
Thank you.
Have
Thank
a
you.
good night.
Good
Bye-bye.
night. So we meet tomorrow again, sharp at 5 o'clock. Thank you. I'm ending the meeting for all. Thank you. Thank you, Manviji.
Thank you, sir.